So how much residual angulation can be expected that will completely remodel? In sagittal plane, 0.9 degree per month of remodeling will happen in apex volar cases. And in coronal plane, the radial deviation will correct 0.8 degree per month. So if there is a 30 to 35 degree of residual angulation, it will need 5 years to completely remodel. So we have to think about the patient says, because the radiological fusion of the distal end of radius ulna in a girl happens in 17 years and in a boy in 19 years. But physiologically it happens a little earlier. So we have to remember that in older children, it may not be totally remodeled if we keep it that way. So there are gallage fracture patterns of different type. There are dorsal type and there is polar type. You can see from the picture. And from this distal radial fracture, which has got a gallage pattern, can be managed conservatively with reduction and plastering. And sometimes they will need surgery too. And we might have to put plates there. So again, coming to our problems, this 7-year-old girl with the distal radius and ulna fracture came to us on the 34th day. And at 34th day, I didn't go for any reduction or anything. And we just waited. And on 82nd day, you can see it is much remodeled, but still there are some deformity. This was a dorsal type gallage pattern distal radial fracture, and with conservative management, even under anesthesia, it was not the reduction was not okay, and we got it on the and we went for open reduction and put 2 K-wires to proximal to through distal to proximal part, and we removed the K smooth pins in 3 weeks so that it doesn't hamper the growth plate, but put the plaster for full 6 weeks. And on the right, on the extreme right picture, you can see the reduction is pretty good, and probably the growth plate was unaffected. So again, looking at this distal radial fracture in 2016, I saw this case, and look at the back. There are big cafe ole spots. Actually, this was distal. This was congenital pseudoarthrosis of distal radius with fracture. We had our plan of excision of the disease part and put a fibular graft there, but the patient came back to me in 2008. This surgery was done somewhere with a very big plate for this small radius, and of course with non-union and probably growth reduced, and 1 K-wire was given in ulna, probably ulnar osteotomy was done. So it came to us in Dhaka Medical College in 2018. We had a plan to go for surgery. The patient didn't appear after that. So this is all extremely sorry that my slideshow didn't work. So many of the slides I could not show you properly here. So what will be the take-home message for us? The distal radial and radial shaft fractures, we have to remember, are the most common and third most common fracture that has to be treated in children. Management is vastly conservative in pediatric population. There are some operative indications, but this surgery or conservative management should be done properly to have good hand and upper limb function. And delayed presentation alters the management protocol, and we have to face it in countries like ours. So my respect to my mentors. On the left, this is Professor K. Wilkins, and the most of the slides were taken from his presentation, his great presentations. And thank you very much. Thank you all.
Now the question answer session. Sir, are you hear me, sir?
Yeah, yes.
Yes, sir. In the chat box, there is only one question is here. The Dr. Saiful Islam question: earlier we know no rotation is acceptable, but you have told 30 to 45 degree of rotation is acceptable. Is it rotation or angulation?
It's rotation, sir. Angulation, I have said, let me tell me about the rotation first. I have given the reference also. In in children below the age of 9 years, 45 up to 45 degree of rotation will correct automatically over the years. In children over 9 years, this rotation the 30 degree of rotation will be corrected. And angulation, I have shown there, 15 degree of angulation will be corrected in below 9 years children, and above 9 years children, at least 10 degree of angulation will be corrected. That information is correct, that 30 to 45 degree of rotation will correct in children gradually.
Another question is, what are the rotational forces acting on the segments of both bone?
So muscles in complete fractures and density fractures, these rotational elements usually work. We know that the biceps and the supinator proximally, pronator teres in the middle part, and distally the pronator quadratus, these are the muscles which actually deforms the forearm bones. These are the main things. Actually, all muscles work. Trauma, the force of injury, everything works, but these muscles are the deforming things mainly.
How you can overcome this problem during immobilization, especially in conservative treatment?
Actually, sir, I have shown that there is apex volar or apex dorsal type of deformity. So, say apex volar with supinated forearm in injury, in injured limb. So, if we just pronate the forearm, and reduce it that way, then it will be corrected, because I have given the opposite force, the force that caused the deformity. Putting the opposite force, applying the opposite force will correct the deformity. And these things should be done in a child under anesthesia, preferably under C-arm, in an ideal situation. But I have shown some cases where we don't have ideal situations. Either they do not agree to go for surgery, anesthesia, or we do not have adequate facilities for anesthesia. In those cases, what we do, I have shown some cases.
Romel,
Sir.
Romel, mention about the cast index.
Well, thank you, sir. Very much important thing. We have to remember that our forearm is a rounded thing. It is more elliptical. In a cross section, it is not circular. It is not like a circle, but it is more elliptical. So the cast index, what sir is telling, the plaster should be widened lateral to medial, and anterior-posteriorly it should be little less. So this is known as cast index. And if we look at our forearm, if you look at our middle or distal forearm, let us see it is not flat, and plaster has to be this much, this type, and this is known as this proper cast index will help us reducing or keeping the reduced fracture.
Any more question, Said?
I have one question, sir. The distal radius, there is a low rate of growth is high, but in the ulna, distal ulnar fracture, there is growth. There can be growth arrest. So,
sir, you are very right, sir.
There is deformity in the ulna, especially, and it causes inferior radial ulnar joint dislocation. How you can overcome that?
In many cases, we will find in distal ulnar injury, there is growth reduction. So growth has stopped due to injury to the growth plate. And it happens. Though both the distal radius and ulna in a boy will radiologically fuse at the age of 19 and in a girl at the age of 17. But physiologically, it stops growing little earlier. But there is incidence where ulnar growth has stopped due to injury and there is deformity.
I have no question here.
I can see some few questions, sir. So I am asking on behalf of Dr. Said Ahmed, sir, to the speaker. The next question is from Dr. Kaisur Rabbi. In case of green stick breakage of an green stick fracture, breakage of the intact cortex, is it a choice or must or should not be attempted?
Kaisur Rabbi, I have shown it there. There are some authors, they have said that while reducing, if you fractured the only one intact cortex, which was intact, there will be two things may happen. Some used to say, which is who are in favor of this reduction, they say with that fracture there will be more callus, more union. And some used to say that with that fracture, the half stabilized fracture will be fully unstabilized. So there are two types of definitions. I think if the deformity is not going to correct, automatically we should go for reduction. And if in that case, if there is a fracture, we have to accept it. And we have to reduce and keep the reduction in good plasters.
Acha Romel, Dr. Kaisar Rabbi, I always in my practice, during reduction, I break the opposite cortex because there is more chance of re-deformation and recurrence of the deformity because you are giving anesthesia to the child. Giving anesthesia is not easy, no? So when you give anesthesia, I always break the other cortex and keep the plaster and correct the deformity and check after a week with the X-ray again. If there is any deformity, then you change the plaster. But I always break because the recurrence of the deformity is much in case of deformity.
Is there more chance of displacement?
Displacement is not a problem, no? Not much. If you keep the alignment okay, your displacement is not that problem. And if you correct the angulation and the rotation and give a plaster, then it is okay.
Okay, our next question is from Dr. Deepankar Nath Talukdar. Bayonet deformity, what does it signify? Dr. Sarwar Ibne Salam.
So bayonet deformity, if you think this is the fracture, this is the bone, and this is the fracture this way. So if it remains like this, this is called bayonet. How a bayonet is fixed to a end of a rifle, you see. The bayonet, if it is a rifle, the bayonet is fixed this way, not this way. So when the reduction remains like this, this is bayonet apposition. So there is volar bayonet and dorsal bayonet. And this is both in shaft and both in distal radial fracture. This is bayonet apposition.
Next question is, if volar type of distal metaphyseal fracture is not reduced by close reduction, what to do next?
Distal radial fracture and bayonet apposition is not reducing.
Not reducing.
Oh, in that case, I have shown one thing. When there is reverse angulation, this means this way and this way, the reduction may not be possible. We can keep it in that way if the child is not old enough. We have shown there the 0.9 degree or 0.8 degree of per month remodeling, and in a 30 to 35 degree, it will take 5 years. So say if the child is say 13 years old, we cannot keep that or 14 years old a girl. So we keep it that way, that may not remodel properly. But if the child is a 10 or 11-year-old boy or girl, that will, in my opinion, in a 10 or 11-year-old, I'll accept that bayonet reduction, and I won't go for surgery or anything, any manipulation. But if the child is 14, 15, 13, then I will go for manipulation like putting a caviar or like that. I'll ask Professor Koiri sir to comment on this.
Yes, the bayonet position is acceptable. I will, the big caution for the juniors, don't go for the open reduction for the distal radiation in children is not very good procedure. Because if you open and destroy the periosteum, this may end up with non-union. Non-union is also common in case of children when you do the open reduction. So accept the deformity and do closed reduction. Accept the deformity, it will remodel. And one thing I want to mention, Rumel, that remember in case of radius ulna in children, remember about this compartment syndrome. Don't give full plaster on the first day of reduction. Give a cast. This cast maybe you can use 6 inches plaster so that it can cover 2/3 of the circumference. Or if you give a full plaster, you must split the plaster. Split the plaster. Otherwise, if you let the child go home after your reduction, there is chance of, we have seen the compartment syndrome in case of fracture radius ulna also. So remember these things. Giving cast, even a deformity you can correct later on. But if the child develops compartment syndrome, this is a real problem. Remember the compartment syndrome in case of radius ulna also, not only in supracondylar fracture.
Thank you, sir. And we should keep the patient admitted, sir, isn't it? We should
no, not necessarily. If you do closed reduction, split the plaster, you can keep it for 24 hours and let the child go home. But
no,
follow up
at least for a night, we should keep the patient admitted, sir.
And check up after a week.
Sir.
Follow up is a must. So remember about the compartment syndrome also.
Our next question is from Dr. Maksud Ahmed. Is there any difference of protocol of immobilization in case of both bone or single bone fracture?
Actually not. We have to immobilize these patients for 4 to 6 weeks, depending upon the age of the patient and callus formation. And we have to, sometimes this single bone fracture management is difficult than the both bone management, because there could be angulation or anything. So we have to keep the plaster for both the cases same period, depending on the age and callus, visible callus. Sir, your opinion, please. Sir, Professor Koiri, sir, your mic is muted.
Yes, sir. I am unmuting him, sir. Just give me a moment. Professor Koiri, you can unmute yourself now, sir.
Yes. Can you hear me?
Sir, yes, sir, we can hear you.
What was the question, Romel?
Sir, which is single bone?
Single bone and double bone. This plaster is same. Sir. Give long arm plaster in case of children. Don't think about the elbow stiffness. There is no elbow stiffness in children. Always long arm cast and long arm full plaster. No short arm. Even in distal radius ulna, it is better to go for in adult we use the short arm plaster below elbow, but in children long arm plaster above elbow.
Okay, thank you, sir. Next question is, what is the minimum age to do fixation in case of shaft or distal radioulnar fracture?
I have said already this. I have shown one website of POSNA, Pediatric Orthopedic Society of North America. They are telling that vast majority of cases are done conservatively unless they are open fractures, unreduced fracture, multiple fractures, those cases. Usually older children may need 13, 14, 15, these may need some fixation, if not their other soft tissue injuries like neurovascular injury or multiple injuries. But this, which I have seen, that this tense titanium elastic nailing, that can be done as early as 6 years, but that is not needed. That is not usually indicated unless those things. I mean, the closed fracture, this soft tissue injuries, neurovascular injuries, multiple fractures.
Okay, I would like Professor Query sir to comment on this, because I have seen there are 4 or 5 questions regarding on this. Is there any specific age bar when we can treat this fracture as an adult and go for open reduction and internal fixation? There are 4 or 5 similar pattern of questions.
Okay. If the problem is not same in the as that in the Western country and in our country. Yeah? Their indication is above 10 years of age, they go treat it as adult and go for the open reduction and elastic nailing fixation. But in our country, yeah, I will advise go for the closed reduction even up to 12 years. And after 12 years, you can treat it as adult fracture. If it is double bone fracture, if it is unstable, you can go for this open reduction. But before 12 years, I always prefer closed reduction, and there will be much chance of remodeling. Less problem you will have.
Thank you, sir. Next question to Dr. Sarwar Ibne Salam again by Dr. Juton Bonik. Type of open fracture, does this has any effect as an indication for open reduction?
I mean, those what we do, type 1, 2, 3 fracture. Actually, there is none, but we know that gastrulate type 1 is many times considered as closed if we just surgically clear that thing. So soft tissue injuries or open injuries are indications of surgery when there is question about managing these soft tissues, vascular injuries, nerve injuries, muscular injuries, skin injuries. Then we should go for this fixation. Otherwise, that doesn't indicate that gastrulate 1 you can go for fixed, gastrulate 3, gastrulate 1 you can go for closed, and gastrulate 3. There is no indication of such type. Personally, I would not go for open reduction in a gastrulate 1, but in gastrulate 3 or multiple fractures or other vascular injuries, I should go for open reduction.
Okay, sir. Next question is from Dr. Taposh Kumar Talukdar. What will be the position of forearm after reduction?
That depends. We have shown that this when the trauma is from the posterior aspect, usually the forearm remains in supination, and volar, the angulation is apex is volar. The angulation is on the volar aspect. So in that case, when supinated forearm and volar angulation of the apex, after reduction, we should keep it in pronation. And when the injured limb is pronated and the angulation is angulation of the apex of the fracture is dorsal, we should keep the forearm in supinated.
But if both bone or if one bone is fractured completely, do you think the same position will be applicable?
Same position. We have to consider the apex of the injury, apex of the deformity. Apex of the deformity will dictate. If it is apex volar with supinated, then we have to keep pronation, and the apex is dorsal with pronated, then we have to keep supinated. Both for single bone or double bone. Same.
Okay, sir. Next question is from Dr. Shamol. How do you prevent plaster slippage in younger children?
Very good question, sir. That is a very very important thing that we need to learn first. Actually, in younger children, when there is more fat, more soft tissues, the plaster may slip. I mean, the forearm or elbow may slip inside that. So we have to mold it properly. We have to mold around the joints like elbow. We have to mold around look at the proximal forearm. Proximal forearm is more rounded and distal forearm is more flattened. So if accordingly to our curvature of our forearm and arm, if we mold it, it will not slip. Moreover, after doing the plaster, we may put up a backup or we may put a full plaster. We have to check it regularly, every 7 days at least. Then we can prevent this, otherwise not.
Okay, thank you, sir. Next question is from Dr. Yunus Ali. He is asking, if we go for open reduction and internal fixation by plating, do we need compression at the fracture site like in adult, or it is not required in case of children?
It's not required usually. In children, it is not usually required. But when we give a compression plate, usually we do that. We always give compression plate. There will be some compression, and that we'll have to do.
Okay. Next question is from Dr. Biplab Mojumdar. Is there any necessity to correct the plastic deformity always?
That is a question, Biplab. If you see the plastic deformity too much, I was telling that the plastic, if it is too much bent, it is better to correct, because this plastic deformity will also correct automatically if it is less. And if the deformity is too much, it has to be corrected. Otherwise, it will take a long time to correct. And in older children, in those children, plastic deformity is less, that may not even correct. So if the deformity is minor or little curvature, we can just avoid it and keep it conservative. But in many cases, we find more in younger children, the curvature is more. We should go for correction of that thing.
Okay, sir. Next question is from Dr. Shantanu. Is there any difference of treatment protocol when patient present with forearm bone fracture with compartment syndrome in case of children?
I don't think we have to manage compartment syndrome and then we go for, in children, as we are telling that we always go for, vastly we go for conservative management, but we have to manage that compartment syndrome, and we open it. If we open it, we have to stabilize the bone. If it is not stabilized without any intramedullary or anything, we have to keep it in plaster. But I'll ask this question to Professor Ram Koiri, sir. What is your opinion, sir?
If you get a compartment syndrome, treat the compartment syndrome first. Immobilize in plaster, do the compartment release, and don't think about the deformity much more, because your viability of the limb is important than your deformity. Your deformity will be corrected later on. I always advise don't go for the internal fixation in our situation, because we get compartment syndrome late. Even if they come even after 72 hours or even after 2-3 days, still I advise release of the compartment. That will save the limb at least. And release of the compartment is not like that of the book teaching that after 48 hours you cannot do that. Release it, it will help. Then try to close it after 5 to 7 days by either by secondary closure or by skin grafting, and immobilize by plaster. I say but you have to, because you have to change the dressing almost every 48 hours or even 24 hours. You have to change the dressing. So don't give any internal fixation. I will not advise internal fixation in our situation, but treat the compartment syndrome aggressively. Don't be conservative in case of compartment syndrome. If there is any sign of compartment syndrome, you will save the limb by compartment release. That's all.
Okay, thank you, sir. Next question is from Dr. Junaid Hakim. Can we give sugar tongue cast for temporary splinting?
in what case? In an open case or in any case?
I think he is talking about open case.
Actually, when there is huge swelling, look at that. I have shown one case which went to Kobira's fast, came to us with huge swelling. So whatever a close reduction or surgery that cannot be done on when we remove that bamboo sticks. So to some form of immobilization is needed for reduction and this the swelling to decrease. So probably that will be helpful in those cases where there is huge swelling or maltreated by Kobirages. We can keep some form of immobilization, sugar tongue or whatever, to reduce the swelling and reduction of the some form of reduction of the fracture. Sir, your opinion, sir?
Yes, immobilize the plaster by a cast, by slab, posterior slab, not by full plaster. And when the reduction comes down, then we apply your plaster.
Specific plaster.
Specific plaster.
Okay, next question is from Dr. Farhad. What is the average time to keep plaster for different type of forearm fractures?
I have already shown that. Professor K. Wilkins used to say this is 6 weeks, but actually this will depend on the age of the patient, of course. In a child of 12, 13, 14, 15 years, 6 weeks is minimum that will be needed. But in a child, say 5, 6 years, it can be less depending upon the radiological features. So in those cases, we can keep it for less, but it has to be there for 4 to 6 weeks, depending upon age and callus and radiological pictures. Sir, your opinion, sir?
Yes, I agree with you. 4 years, 4 weeks. This decision saying that 4 years, 4 weeks. Below 4 years, above 4 years, 6 weeks. This is a rough idea, but that depends on the X-ray.
Good insight.
Okay.
Below
okay,
4 and above 4, 6.
There are 2 or 3 questions regarding iatrogenic development of radioulnar synostosis, either by closed treatment or by open treatment. What will be the management afterwards?
Well, that is a very difficult situation to be managed. I haven't managed any case like that. I have seen iatrogenic radioulnar synostosis. After the soft tissue injury, soft tissue will heal. Probably then I'll go for this synostosis part to be released and reapplied. And maybe I'll put some inert substance, fat or something like that in that interosseous space. Sir, I don't know what to do in iatrogenic
radioulnar synostosis. The question is either in the sept, cross union they mean, or radioulnar synostosis.
I think they mean cross union, sir.
Cross union. If then you have to see what the position of the forearm or hand is. In the child, in the right hand and in the left hand. If right hand, if it is fixed in complete supination, so you have to make it in pronation. Wait for remodeling, and then you can go for the osteotomy, radioulnar osteotomy, to correct the deformity, to make it a mid-prone position so that he can eat or write like that. And radioulnar synostosis, usually that happens in case of radial neck fracture and comminuted fracture of the proximal ulna and radius. There may be radioulnar synostosis. That should be treated like a congenital radioulnar synostosis of the proximal radius and ulna that we get. We have to go for the osteotomy. That should be a separate lecture, you know. We can go for the osteotomy to correct the one on the right side. If it is in the dominating hand, right hand, then you have to keep it in mid-prone. If in the left hand, you can keep it in pronation or in supination. That is the treatment of the radioulnar synostosis. But this is very rare. It may be common in open fractures. Thank you.
Okay, thank you, sir. Next question is, can we use external fixator or K-wire instead of plaster after release of compartment syndrome?
Well, sir, he's asking external
about
fixator. In many cases, we can open fractures, we can use external fixator.
You can use external fixator even after. He's asking about the compartment syndrome.
Yeah.
Release of compartment syndrome. Yes, you can use external fixator in older children. Older children, we can use external fixator. Yes.
Okay,
Any more
you,
question,
sir.
Bobby?
No, sir. I think all other rest of the questions are almost similar types. So I think
can,
now it's the time we can. We are going to unmute
the
everyone,
senior.
but only the senior doctors are requested to unmute themselves and ask their questions. Thank you. I am giving the authority to unmute everyone.
Hello, Bobby.
Sir.
Bobby.
Sir.
Dr. Mohiuddin wants to speak.
Yes, sir. I unmute kore dicchi, sir.
Yeah.
I'm giving them.
Okay.
Okay. All the senior teachers can unmute themselves.
Hello,
and
Bobby.
talk with us.
Hello, Bobby.
Yes, sir.
Hello.
We can hear you, sir. You can ask.
Professor Dr. Gulam Farooq. Can I say something?
Yes, sir.
Yes,
of
sir,
course, you
please.
can, sir.
I can hear you, please, sir.
Thank you. Probably there are some problem in your presentation, technical fault.
Sir.
Although Dr. Sarwar, your presentation was excellent, like your previous presentation. I have a message, first of all, Dr. Kadir from Ulna, Nasir Hospital. He is admitted in Evergreen, that is Apollo Hospital with Corona in HDU. I requested all to pray for him for his early recovery. And my question is to you, have any experience about the treatment of radius ulna by elastic nailing? Have you any experience of the radius ulna with elastic nailing in your institute?
Yes, sir, I have experience, sir. I have shown one X-ray. That was a 14-year-old boy, and that was initially managed conservatively with plaster, but it seemed that reduction was not acceptable. Then we have put that elastic nail in both radius and ulna. I have shown the picture here in the presentation, sir. 14-year-old boy.
Yes, I have seen that, but it is single case.
Now we have done more. We have done more, sir. We have done more. I have shown only one case. We do not do it routinely, but in some cases we have done when we thought it is indicated.
Bobby,
okay, thank you.
Bobby.
Dipankar.
I have some talk, sir. I've got adequate test and adequate literature support regarding the synostosis in the postoperative or post-traumatic. It in the literature text support, it should be excised meticulously after 1 year. That is the when synostosis will be the period. In the text it is written, and it should be covered with the soft tissue. Number one. And regarding my question, what bayonet deformity signifies? It signifies that is the overriding. And overriding bayonet deformity up to 1 centimeter can be corrected at within the age of 9 years, and should be less than 1 centimeter above the age of 9 years. Okay. What is the another answer addition plus Shamal's question? How can we reduce the slipping? It should be slipped by 3-point molding, already Sarwar told, interosseous molding, and another two very important, supracondylar of the humerus molding, as well as the extension of the plaster up to the thumb. In case of children, it is written in the text as well as the literature also. And another answer to the rotational deformity. Rotational deformity in the children not only due to the muscle action, but when the incomplete flexures, there is rotation. Say there are 3 deforming force acts on the green stick deformity. Third is rotational. It is due to the initial force during the forearm either pronation, supination, or midpoint position. This is the called rotational deformity by the initial force of violence when the forearm remains in the form. This is, I am sorry to. Oh, sir, sorry, sir. And another text support in the compartment. Yes, compartment support in the what sir said, exactly 100% adequate release of the compartment, neurolysis, blood vessel release, and
Blood vessel
bicipital
release.
as now blood perivascular around the
What is it?
plus it should be fixed intermedullary. Definitely it should be fixed.
No,
Not
No,
it,
no.
read it
no,
in the
no,
book.
no.
I
No,
can
Not always.
No, not
Acha,
always.
okay,
Yes.
ठीक है sir. Not always.
agree
Not
with
always you
Prof.
can fix.
Okay.
I agree with Kori sir.
Not always you can fix. Yes. Okay.
You
Thank
go
you.
through,
Thank you.
okay, Wilkins book it is written other only I don't
But
know.
in Western situation.
Thank you, sir.
No,
Thank you very much.
okay.
Thank you,
Intermediate thickness,
Dipankar.
not extremity. Oh, thank you, sir.
বারি স্যার আসসালামু আলাইকুম কিছু বলেন
Walaikum salam.
কিছু বলেন স্যার আপনি
One, not bola, I mean, one question to Sarwar and Kwarida.
Hey, why my video is off?
Fracture at or distal radius ulnar, metadiaphyseal function, metadiaphyseal junction, you can treat it with by K-wire. If you go for intermedullary nailing, you are getting angulation of the ulna. What is the reason behind that? This is number one question. Can you follow me?
No, sir, I didn't understand the question, sir.
Fracture at or distal to the metadiaphyseal junction can be treated by percutaneous K-wire. If you go for intermedullary metadiaphyseal, I'm talking. If you go for the intermedullary nailing, you are inviting angulation of the ulna. What is the reason behind that? This is number one question. And you know the Professor Lascombe is from Paris, Switzerland. I saw his one lecture regarding these Lascombes, well-known pediatric surgeon from Switzerland. He has done all the cases of radius and ulna by intermedullary elastic nail. And he has got the technique. And his colleague was also Prevot and Pierre. So far I remember, they are doing this. What's your comment regarding this?
Sir, I'll answer first and then shift it to.
Okay, please.
My question was metadiaphyseal fractures can be treated with K-wires. I have shown one case that we have put K-wire. This can be done conservative, but in all the cases, in many of the cases, we cannot do it conservatively. We need to go for some form of fixation. And I have shown one case, sir. We have put 2 K-wires, removed those smooth pins after 3 weeks, and kept the plaster for 6 weeks that I have shown here. So, and I don't know anything about intramedullary fixation of a metadiaphyseal radial fracture. I didn't tell it here, and I don't know whether that is possible or not.
I have seen yes, I have seen the literature. If you go for the intermedullary nailing, you are inviting angulation of the ulna. What is the reason behind that? But reason I could not find. And that's why they are advocating this. This is Quaridan for you.
There is a minimum or no intermedullary space in that metadiaphyseal space to
especially ulna.
And one about Professor Lascombe, yes sir, and this intermedullary fixation is done hugely in India, and Professor Sandeep Padwardhan is doing with K-wires even. They are doing, many of the Indian pediatric orthopedic surgeons are doing this intramedullary rodding with telescopic nail, with elastic nails or even K-wires, because there are some patients, some parents, they want their bone to be straight, not that overlapped or bayonet. In those cases, they are doing so.
Right.
I think this should be surgeon's choice. Sir,
not only surgeon's choice, Rumel, Baribhai.
Yes.
In our country, this is our situation is not like Bombay or Pune or even Western countries. Our sterilization procedures and our OT facilities for the juniors are not that much adequate. So I will not advise open reduction in case of children in our situation. You have to convince the parents that it will remodel.
Correct.
Because there are a lot of cases. Yeah, let me say there are a lot of cases to do now, but don't invite problem in case of children in our society. And the Bombay society is like that of Western society. You know, they will not accept the deformity. They will see the X-ray and they will ask the doctor to fix it in accurate position. So this is like that. The Sarwar was telling that it is more prevalent of open reduction in Bombay, Pune, and the greater cities of the India. But I will not advise the juniors to go for open reduction and fixation in closed cases, in case of children in our society. That is one question. The question by Professor Bari Bhai has asked about the angulation of the ulna in case of internal fixation of the radius. If it is a double bone fracture, many a times, even in closed reduction, you can reduce the radius and you can see that the ulna is not reduced. Even in bayonet position, you have reduced the fracture of the radius, diaphyseal, metaphyseal fracture, but ulna is not reduced. And then in children, I accept it. I also don't know. Probably the pronator quadratus may play some role, but I don't know that if you reduce the radius, ulna is not reduced.
Thank
if you
you.
try to reduce the ulna, then radius is also displaced. So accept
Hello,
the
sir.
main board is radius. Yes.
স্যার বারি স্যারের কাছে অ্যানসার আছে কিনা স্যার?
Hello, hello, hello.
অ্যানসার থাকলে তো আমি জিজ্ঞাসাই করতাম না।
স্যার
না স্যার অনেক সময় থাকে স্যার।
স্যার একটা জিনিস স্যার ওই যে ইন্টারমিডিয়ারি রড স্যার ক্লোজ স্যার, ইন্টারমিডিয়ারি নেলিং যদি করা হয় ক্লোজ স্যার, আমি যে কেসটা দেখাইছি ওটা আমরা ক্লোজ করছি স্যার। আমি ওপেন রিডাকশন স্যার রেয়ারলি করছি স্যার, ওই ওপেন বা ই ছাড়া ওগুলা স্যার ক্লোজ।
না, there are some indication after 10 years of age, double bone fracture, unstable fracture, fracture at the same level of the radius and ulna. You can go for the facilities available. You can go for the elastic nailing. Nailing in radius and ulna.
And can I ask another question to you? Is it possible to ask another question?
Bobby, আচ্ছা দেখো তো এর
যে মহিউদ্দিন কথা বলতে
মহিউদ্দিন
বলবো।
Sir, my
মহিউদ্দিন
video
ভাইয়ের
is off.
ভিডিওটাও
দিয়ে দিও।
মহিউদ্দিন স্যারের ভিডিওটা অফ হয়ে গেছে।
আপনি নিজে
All options are open, sir. They can unmute themselves, sir.
Now, my mute to unmute kora hoise, but my video is off by host.
Video can
Okay,
be done by
you can start your video now, sir.
Yes,
we can see Mohidin bhai in black t-shirt.
Thank you to Koiti sir and Bari sir for
আরে
their
বাবা
excellent presence here.
সুন্দর ড্রেস।
And thank you to Romel for his nice presentation. I want to talk on caste index. Koiti sir asked about caste index. Romel nicely said, but caste index is a index, is a ratio. And anteroposterior diameter of the internal diameter of the cast and lateral diameter of the cast in X-ray. If we divide it, if we get 0.8, if it once it will be more, both will be equal. But if we get less than 8, the chance of displacement will be less.
0.7 is acceptable.
0.7.
0.7, but 0.8.
This is called Canadian cast index. This is called Canadian cast index.
Sir, 0.8, if we get 0.8, the chance of displacement will be 4.6.
Right.
If it gets above 0.8, the chance of displacement will be 26%.
Yes. Below 0.7, acceptable.
Okay, sir, 0.7.
0.7 to
0.7 point is all the same.
0.8. It should be below 0.8.
Cutoff point.
Mohidin is telling, I think, from literature. He is telling from literature what is this importance of this thing.
Yes,
If it is above 0.8, if it is above 0.8, this is the percentage here in this literature.
Yes.
I think he is reading the literature. Yes.
Yes, sir. Sir, regarding angulation, Romel nicely said, but I think there should be volar angulation, how much acceptable, and dorsal angulation. In case of if age is less than 9, the dorsal angulation is acceptable up to 39 degree, and volar angulation up to 23 degree. And there radial angulation.
Distal fracture or shaft fracture?
Distal fracture.
Distal fracture, a lot of angulation can be corrected.
Yeah. There are 3 types of angulation. We have to volar angulation, dorsal angulation, and radial angulation. We have to.
Radial angulation is bad. Sometimes it impinges on the.
That's why radial angulation is less acceptable. more
Less
Less
active.
corrected. Less corrected.
Its measurement is just like the bowler angulation, more or
Yes,
less.
and
Radial
Distal 30,
here
bowler
is
15.
Yes.
benefactor, it is overriding.
অর্ধেক কি?
Here we are accepting one, there is no angulation or no rotation is acceptable, but when there is only overriding, then we can do it by only plaster, no anesthesia, no manipulation, no other manipulation.
Overriding up to 1 centimeter.
Up to below
Yes, sir.
1 centimeter. Yeah.
Below 9.
Yes, up to 1 centimeter.
Ah,
And respiration is also there. Regarding KOR insertion, after reduction of the distal radius, we can put the KOR through the growth plate and also through the cortex. But it is easy to place the KOR through the growth plate. But it is better to avoid this. But if you want, but if you put through the KOR through the growth plate, there is no harm. There is a literature that after removal of KOR, 3 months later they have gone for MRI and there was no growth plate retardation or there was no growth plate deformity was there. So we can use.
Mahyuddin, yes, you can use KOR, but no multiple attempt.
Yes,
one,
sir.
yeah, one
attempt is better, but we can go for 3 attempts.
Maximum up to not more than 3 attempts. You know?
Yes, sir. Not more than 3.
And smooth KOR.
Yes, sir.
Smooth KOR.
Smooth and thin KOR. And thin KOR.
Sir, Professor K. Wilkins has said one thing. In my case, what I have shown, I have given from epiphysis, physis, and metaphysis. But Professor K. Wilkins is telling that you can use put the KOR this way, that it acts as a fulcrum on the epiphysis, avoid the physis, and enter through the metaphysis and go proximally. So that is also a good thing to see, and that KOR can be kept for a longer period. That is one thing. 3 weeks is accepted everywhere, that 3 weeks it will not hamper the growth plate. But there are studies that Mohiddin Bhai said, there are studies that even longer period smooth pins, as sir said, don't try for many time. Just put it once under CM.
On the next lecture of Bobby, we can discuss about this epiphyseal injury. But remember that even a fracture lower end of the metaphyseal fracture of the lower end radius and ulna, there may be associated epiphyseal injury. And there are cases that radius ulna metaphyseal union is good, but there is epiphyseal damage. So there are some exceptional cases. We can discuss it on that day.
Can I tell something?
To ask something, sir?
Can I tell something?
Yes, Mainuddin. In short,
thank you, sir. Thank you, Dr.
We'll continue for 5 minutes more. So.
Sir. Thank you, Dr. Rumel, for a nice presentation. I think everything he has touched, but some things I want to say in a conclusion, something such a way. In green stick fracture, whether we should break or not, whether I should continue. Already, query, sir, it is clearly answered, but there is a 2 schools of thoughts always.
That Rumel has already told.
Already answered this thing. I was saying that there are many questions about this thing. And another question was that whether we should keep the long arm plaster or short arm plaster. There is a literature which was published in 2006 and in the Journal of Injury and Orthopedics and Injury. They told that there is no difference of effect if you keep the long arm full plaster or the short arm full plaster in case of distal or metaphyseal radial fracture. But in our practice, from our seniors, and we always see that in the children, we cannot believe that giving a short arm plaster. So we always keep it in the long arm plaster to keep it in the position. So I also agree with Professor Koiri sir. It is better to give the long arm plaster, not to give the short arm plaster. Though literature says there is no difference between the long arm and short arm plaster. We have to cases properly, and we have to counsel with the parents that after the reduction, our literature says that we should reduce it under full general anesthesia. In the distal radius fracture, we should, but our facility is not such large, just like is the Western country or India, such a way. So if we reduce it, we have to check it every weekly whether it is displaced. The main chance is that there is a displacement of the fracture. again.
First 2 weeks. First 2 weeks.
Yes. So,
First 2 weeks.
And Dr.
sir,
And Dr. Samad.
so we have to counsel with the parents that there may be the displacement. I have to need another manipulation again. So they tell that if the fracture comes within the 7 days or 10 days, you can take another chance for the remanipulation. But may not do the remanipulation if the children age is much more, because age is less, it may be remodeled. But if it is more, you can take another chance within the 10 days again. So you have to counsel with the patient. There may be the displacement.
Okay, Samad sir then. Samad sir,
Vice President POSD.
Sir, the thing is that the 3-point fixation, the plaster 3-point molding is most important. Whether you can, they have
to Manuddin.
Yes, sir.
Manuddin, একটু সামাদকে কথা বলতে দেই দেখি।
Thank you, sir.
Samad, Professor Samad.
Thank you, Professor Koirida. Thanks, Sarwar, for good discussion. And I want to say one thing, that in case of the obese children who has come with fracture, fresh fracture with huge swelling, and then what you'll have to do, we'll have to do, you know everything, I think you all, but we have to delay for some time in hanging the limb in cast for 48 to 72 hours. Then if we go for reduction or go for pinning, especially the distal fractures of the metaphyseal as well as near the joints, distal radial fractures, it will help us for not inviting the compartment syndrome or other complications. This is my suggestion.
Thank you. This is good suggestion.
Requesting permission to speak for 1 minute, sir.
And one thing, before the fracture management, we all always know that think before you start, and think before you reduce, and think before you hold, and think before you operate. These are the aphorisms in children fractures or in all other fractures. We should know, and we should remind before treating the fractures of the children. This is my concern. Thank you, Professor Koirida, and all who have
Thank you, Samad. Thank you. We are glad to see you today.
Thank you.
Not seen for many days. Glad to see you.
Thank you. I'm sorry.
Every week.
Every week.
I think every week you will join.
Yes, thank you.
Right, sir. All request.
Sir, requesting permission to speak for a minute, sir.
Yes.
I would like to highlight on one point regarding the angulation of volar angulation and dorsal angulation, what Dr. Sarwar Ibne Salam has said. So the ideal scenario is you have to find out that whether if there is any complete fracture or incomplete fracture. That should be your main concern, sir. If there is any complete fracture, either in one bone or in both bone, the position of the forearm should be treated like an adult. Superior 1/3, keep it in supine. If the fracture is in the middle third, keep in mid prone. If the fracture is in the lower third, keep in full prone position. But if both bone or single bone is incompletely fractured, only in that case, all volar angulation should be in pronated position and all dorsal angulation should be in supinated position. So we have to remember, if any complete fracture is present in either one or double bone, treat it like an adult position. But if both or single bone is fractured in incomplete fashion, producing volar angulation, keep it in pronation. Producing dorsal angulation, keep it in supination.
Angulation
recommendation. Yes.
Volar angulation, that is anterior apex.
And apex angulation. Apex angulation. Thank you.
Anterior volar apex.
Romel.
একটা ডিক্লারেশন আছে স্যার।
ডিক্লারেশন দিয়ে আজকে শেষ করো।
তারপর আপনি শেষ করবেন স্যার। So next few meetings on 26th, the session will be chaired by Professor Abdul Samad, and it will be moderated by Professor Moinuddin Ahmed Chaudhary, and the speaker is Professor R.R. Koiri, and the subject will be Montegia and Miss Montegia lesions in children. On 3rd July, the speaker will be Kaji Shoidul Alam Bobby, and the subject is facial injuries management of facial injuries. On 10th July, and we'll start with upper limb, and this speaker is
lower limb.
lower limb, sir. Sorry, lower limb. And the speaker is Professor Shamal Chandra Devnath, and he will be speaking on proximal femoral fracture in children. And on 17th July, the talk is on fracture shaft of femur, and it will be done by Dr. A.K.M. Johiruddin. And on 24th July, this is the subject is pediatric leg and ankle fracture, and that will be done by Professor Parvish Shaidi. So I'll let you know regularly, and every Friday 8 to 9 p.m. is pediatric cases. And after trauma, we'll start with orthopedics, pediatric orthopedics. Sorry, thank you, sir.
So thank you, Dr. Rumel. Thank Dr. Rumel, and thank all the seniors. Thank all the seniors. So we'll meet next week on Friday. Thank you all.
Thank you, sir. Thank you.
Thank you once again.
Thank you, everybody. Assalamu alaikum.
Assalamu alaikum.